So thank you, Professor Rajesh, for the invitation. Uh, so I'm going to speak is contact lenses the mainstay of treatment for visual rehabilitation in keratoconus. Uh, and the various contact lens used in the optical correction of patients. As we all know, we have heard various modes of optical correction or C3R, whether patient is pre-op or patient has some form of C3R done or some keratoplasty or lumbar procedure done. All of them need some form of optical correction, and almost 80% of the patients of keratoconus needs contact lens in some form or the other. Way back in 1998, CLEC study showed that almost 65 to 70%, 75% of the patient of keratoconus needs contact lens, especially rigid gas permeable lenses, and only around 10 to 20% of the patient will require some form of surgical intervention. Of late, this figure has also further reduced to around 10 to 15%. So most of the patients fitted with contact lens are having a vision when it cannot be improved beyond 2030 with the glasses. And there are various options of different types of contact lenses in these patients. In mild keratoconus, where the K readings are flatter than 45 or maybe they are there's mild keratoconus. We have option of these soft toric lenses or hybrid lenses, conventional RGPs, piggyback or ROS K2 lenses, and moderate cases where the K readings are 45 to 52. We have ROS K2 or hybrid lenses, and in advanced keratoconus, we have option of scleral or the ROS K2 lenses. And depending upon the type of cone we have, whether it's a nipple, oval, or a globus cone, we have to choose the contact lens accordingly, because in like if the cone is too large or a globus cone, it will typically warrant a design with the larger diameter, and diameter of the contact lens is based on the location of the cone, its size and steepness. And coming to the soft toric, they are only helpful in early keratoconus cases, but they are quite easy to handle and they give good comfort to the patient. But the cones, the downside is they correct only low amount of cylindrical power and vision is compromised. So the indications for these soft toric lens are only early keratoconus or where RGPs are not tolerated, and as they fail to mask the corneal astigmatism. The Kerasoft is another type of soft contact lens which are available in conventional hydrogel or silicone hydrogel lenses. They have relatively flat base curve and they also neutralize the aberrations to some extent, and the special design to drape over the cornea instead of masking the irregularity of the cornea which is the usual mechanism of ROS K2 lenses, is the basis of this lens, and they are good, have a very good comfort, and they are simple in handling and highly customizable, and they can be used in mild to moderate keratoconus. And but the downside is vision is not that crisp as they are comfortable, but it cannot be used in advanced cases of keratoconus. We have this publication from our center where we compared ROS K2 with the Kera soft lenses, and we found that though Kera soft lenses were comfortable, the vision was better in ROS K lenses in terms of contrast sensitivity. So Kerasoft lenses can be considered as a good alternative for optical correction of corneal astigmatism in patients with keratoconus who don't tolerate RGP lenses. Then coming to the RGP lenses, which are the mainstay of optical correction in cases of keratoconus, and they are made of their decay value is very high, they are quite affordable for the patient, and very crisp vision is there, and can be used in mild to moderate keratoconus, and though initially there is a low comfortability, but as the patient uses it, they become more and more tolerable, and they are also suitable for high cylinder and irregular cornea. The rose care design is different from the traditional RGP design. It's a tri-curve design, so it drapes around the, so you can see in normal lenses they have a pool around the cone, but the rose care tri-curve lenses, they conforms to the cone of the lens, so that there is no pulling of the tears, and the oxygenation of the cornea is not affected. And in further designing of the lens, rose care 2 lenses, they are aspheric, as well as their optical zone is larger, so the quality of vision and the field of vision is much larger. And I won't go into details of fitting method, but the most important is there are three different fitting philosophies, either apical bearing, apical clearance, or 3-point touch, and the 3-point touch is the most widely accepted one. So once you fit in a contact lens, you should be looking for a gentle touch in the center, mid-peripheral bearing, and there should be an adequate zone of 0.75 to 1 millimeter edge elevation, and the lens should be assessed in a dynamic form immediately. You have to wait for half an hour, and immediately after blink you can see there is a very feather touch in the center, and if you wait for some more time, there will be less and less of pulling as the dye clears up, and there should be appropriate edge lift so that the exchange of tears happens. And as you can know, if there is too much of apical bearing, it will lead to scarring, and if there is too much of steepening, it will affect the oxygenation of the cornea. And there is one representative patient with severe keratoconus. The patient came to us from outside. He was already using these lenses, as you can see, because these lenses are too flat, and it has led to a apical scarring in both the eye. So we changed the lenses and and these are decentered also. There are inferior shift of the lenses in both the eye. So fit has to be proper so that the quality of vision is not fluctuating, and you should avoid any apical bearing or too tight lens. This is a publication we did way back in 2006, and we showed that almost 100% patient with moderate keratoconus can be fitted with those K2 lenses, and almost 90% of the patients of severe keratoconus can be fitted with rose K2 lenses, and chair time is much less, and only 1 to 2 fits are required to do this. Coming to the scleral lenses, as we all know, these are defined as a lens fitted to vault over the entire cornea, including the limbus, and to land on the conjunctiva overlying the sclera. So the advantage of these lenses is they have a good comfort, lens stability is there, they are highly customizable and correct advanced cases of keratoconus. But for patient, the lens handling is little difficult, but they learn it over a time, and they are also very expensive and they are ideal for the intolerant rigid lens wearer, regardless of the stage of the disease, and they may delay or avoid the need of surgery. So what is the lens anatomy? It has a central clearance zone, and there should be a clearance of around 150 to 250 micron in the central area, and the mid-peripheral zone is limbal independent transfer zone, and it should be around 50 to 100 micron. So the clear space gradually taper to the periphery, and the scleral landing zone is an angle that aligns on the sclera and bearing the sclera bearing sector of the lens. And based on the size of the lens, they can be classified into corneoscleral, semiscleral, miniscleral, and full scleral lenses. And this is how you access. After putting the lens, wait for adequate time and see the clearance between the two. The guidance is compared to the thickness of the lens or thickness of the cornea, or if you have, and these are the fitting parameter. The 50-50 rule is applied. There should not be too much of impingement or too much of elevation of the lens edge. There should be 50-50. This is the good alignment. This is edge elevation, and this is impingement. This is the ideal fit, and this is one represented patient with sphere keratoconus. And this is the, if you have OCT, one can use OCT for this. You can see the clearance between the lens and the cornea is 235 micron. This is the right eye. If you think this is too high, you can fit another lens, and this is the adequate wall. Just one or two slide. And this is the left eye of the patient with 300 volts, so it needs to be around 150 to 200. And this is the both eyes of the patient fitted with the scleral lenses. And this is post keratoplasty. You can see the adequate clearance of this lens. So coming to the final conclusion, so we can divide keratoconus into different stages, and depending upon the stage, you have different options of treatment. But whatever treatment you give, you need some form of optical correction, be it spectacle or contact lenses. So contact lenses alone or in combination with different procedure are the mainstay of optical correction of keratoconus patients. Thank you so much.
Thank you.